Dear colleagues, dear ladies and gentlemen, thank you for the invitation. Thank you for the organizers for the possibility to talk about pain management of the critically ill patients. That's what I'm going to overview this morning. I have no disclosures at all. So let's start with why pain matters on the ICU. Usually when we are having critically ill patients, we are not always having the first thought about pain. The patient is in cardiovascular damage and the patient is unstable, hypoxic. But we have to know that pain is extremely common. So about 1 in 3 ICU patients has pain in the rest, and the 3/4 of them has pain during the procedures. What we are doing with them, and if the pain is inadequately controlled, then there are a lot of worse outcomes of pain. Or an ICU. So we have stress response, we have delirium, prolonged ventilation, longer ICU stay, but we also have chronic pain, PTSD, when the patients are surviving the ICU period. And very importantly, these ICU survivors, they consistently rank pain control as one of the top priorities. So the International Association for Study of Pain made a declaration in Montreal in 2015 that stated that the right of all people with pain, there is a right of all people with pain to have access to appropriate assessment and treatment of the pain by adequately trained healthcare professionals. So we have guidelines. The guidelines have evolved in the past 15 years. We had the PAD in 2013. We had the PADIS 5 years later, which added the term prevention, sedation, and talked about the immobility and sleep disruption of the patients we are treating on the ICU. And in 2015, there was an update of this PADIS guideline, which added anxiety as a new domain and also refined the sedation recommendations and highlighted the sleep and mobility suggestions. And also there is a big innovation that ICU survivors were included as co-authors in this update, the latest update. So how do we assess pain on the ICU? The gold standard is the patient self-report. We can ask the patient to grade the pain from 1 to 10 on the numeric rating scale, but most of the patients or many of the patients are unable to do that, so we can use these validated tools, the critical care pain observation tool, the behavior pain scales, and as you can see on the little drawings, that facial expression, movement of the upper extremities or other movements, muscle tone, and tolerance of the ventilation, they are the parameters we are trying to see and to assess, to grade those patients' pain. Very importantly, the vital signs, what we are seeing are not reliable indicators. So if the patient doesn't have hypertension and tachycardia, that doesn't mean that the patient doesn't have pain. So we have some novel parameters what we can use. We have pupillometry, which takes a look at the pupil dilatation for nociceptive stimuli, and we have a nociception level index, and also the family and nurses can act as a proxy reporters for the patient's pain level. So what are the sources of the pain on the ICU? We have, of course, the ventilation, intubation. The patients are after surgery or they are after a trauma. But we are doing a lot of things with them. We are turning them, repositioning them, suctioning the tube. We are doing cannulation, drain, insertions or removals. And we really have to be careful to prevent and be preventive and preemptive before these procedures to prevent the pain what we are causing with these procedures. Immobilization is a very important source of pain. So with mobilization and early exercises, we will see that we can do a lot for our patients. And of course, organ failure and other medical conditions, abdominal pathologies can cause pain to the patients. So in the old days, the usual approach was sedato-analgesia. That meant that if we have a critically ill patient, we sedate the patient, so the patient is not going to react, and then we think that it's no pain. And if we were conscious enough, then we gave analgesics. But from the PADIs and updated PADIs, we know that there are better approaches like analgesia first sedation. So we use the analgesia before we are starting the sedation, and then that will reduce the need for the sedatives, that will reduce the ventilation time, the duration, the ICU length of stay. And also we can distinguish between analgesia first and analgesia-based approach. If the patient doesn't need, we don't necessarily have to give the sedative if the patient is in comfort with adequate opioid or analgesic medication. When we are talking about the treatment of pain on the ICU, we usually think about drugs. First choice is always opioid for critically ill or severe condition patients. We have to tell that remifentanil is a nice kid in the block because it has a rapid offset when we are stopping, and we can predict the clearance. We can give the fentanyl for the renal patients. But we also use a lot of morphine and sufentanil, and don't forget about the methadone, which is very important in the withdrawal. Because the opioids do have risks and side effects, as we know, the tolerance. If we use it for a long time, the major opioids, then there will be a lot of withdrawal syndrome, respiratory depression, constipation, nausea, and vomiting. We all know, but delirium is very important. If we give a lot of opioids, we will have more delirium. And also, opioids are connected with longer ventilation again, longer ICU lengths of stay, but immunosuppression and opioid-induced hyperalgesia as well. So what can we use apart from opioids? We have some other pharmacological possibilities. We have paracetamol, which is rather central acting drug. We have the metamizole, which is mainly COX-2 inhibitor and also has central nociceptive and inflammatory modulatory effects with just minimal COX-1 effect. We also have the neuropathic agents, the gabapentinoids and carbamazepine, what we can give not only for neuropathic pain, but gabapentinoids are now gaining interest in the perioperative medicine, and many of the anesthetists give it as a pre-medication for the patients before the surgery. We have the N-methyl D-aspartate receptor inhibition. We can do that with ketamine, or we can do it with plain magnesium. So this also has a role in the pain management. And we have the alpha-2 agonists, dexmedetomidine and clonidine, but we are using more and more dex, which has a lot of different kind of effects we will see. But before that, I will also highlight that the latest PADIs updates, they suggest that we should avoid the routine giving of lignocaine, IV lignocaine, and the COX-1 inhibitors, the non-steroids, because of the renal side effects. So dexmedetomidine is a very colorful guy. It has analgesic properties. We know that it has opioid-sparing effect, but when compared with other sedatives, it didn't really have the advantage or no difference in sedation. In the SPICE-3 trial, they compared it with usual sedation in quite many patients, and there was no difference in the 90-day mortality, but there were advantages in terms of coma and delirium days. Of course, there are cardiovascular adverse events, and it is only good for light sedation. Sometimes we cannot achieve the targets alone with the dexmedetomidine. There are different mechanisms of the DEX analgesia. It is inhibiting the A and A delta and C fibers in the periphery. There are central effects by inhibiting the spinal cord's pathways of the pain signals. And there are local analgesic effects too. They modulate the hyperalgesia. Also ketamine, which was mentioned earlier, we had some recent meta-analyses from, actually this is from the same group of researchers, and they were looking at ketamine after thoracotomy, and also in acute pain, and in both settings, the ketamine use was lowering the pain levels and reduced the opioid use, and also the postoperative nausea and vomiting. And also they took a look at how do we use it for the sedation, and actually it was not inferior, and it resulted in less delirium. The other thing, apart from pharmacological interventions, is regional anesthesia. It is really underutilized in the ICU, but it can provide really excellent pain relief and reduce the opioid use, the delirium, and hence it can provide better mobility for these patients. There are a lot of studies about erector spinae block, but there are other plane blocks for the like serratus anterior plane blocks. They are very good in trauma, rib fractures, thoracic and abdominal surgery. After cardiac surgery and sternotomy, we use quite a lot of pecto-intercostal fascial plane block, which is a really easy and simple procedure, and it just zeroes down opioid use in the first 12 hours. Transversus abdominis plane block, rectus sheath block, we can use catheters there, and actually compared to epidural catheters, we have much fewer hemodynamic issues. So we can use it in vasopressor patients and also in anticoagulated patients, because these are mostly superficial blocks, so especially with ultrasound, they are really not with high risk. The non-pharmacological approaches are very important. I don't know how is it in your departments. Music therapy and massage is not really available in our department, but there are studies for that, and they really reduced opioid use. But I think sleep hygiene is something that we can achieve. If we can do the appropriate day-night orientation for the patients, we can really improve the comfort and reduce. There is data that it is reducing the delirium and anxiety of our patients. Family engagement. Professor Molnar's ICU is already really good at this, because it's an open ICU. For the families, they can come at any time when they are not disturbing the treatment of the patients, which is really exciting, and it really improves the pain assessment accuracy and also the pain perception of our patients. Safe environment. I think it's really important if we have nurses who are attentive, mindful, and kind, which is really difficult when we have nurses and doctors who are really burned out. But still, we have to try to be kind and attentive. That will give safety for the patient, which will really improve the overall the overall comfort. Virtual reality, there were trials on ICU to try providing virtual reality sessions to the patients, and it did reduce pain and anxiety in these trials. And very importantly, again, the early mobility and exercise is a thing which will decrease the pain level and pain perception of these patients. Delirium and sedation is in very close connection with pain management. On the ICU, we know that pain is a main risk factor for delirium. So if we don't treat the pain, it will worsen all the outcomes. We have the ABCDEF bundle. We all know the first guy is about pain, assess, prevent, and manage pain. And of course, we have to take care of all the others. There was already a study, the ICU Liberation Collaborative. This study looked at more than 15,000 patients using this bundle, and it really showed improving outcomes in these patients. There are also always barriers to the, how to implement these things from the guidelines. ICU staff, which means doctors and nurses, less than half of them is assessing the pain regularly. This is really something we can do better. Also, again, doctors and nurses have beliefs about opioids and sedation, which are not always in close connection with these guidelines. That can override the adherence to the guidelines. Workflow is not always easy. Financial and human resources are poor, and the working culture is sometimes also poor, and these can be really barriers to how to implement all these nice things which we were talking about. So what I would like to highlight from the things that we should assess the pain systematically. Analgesia first is a best and good practice. We have to use multimodal bundles, not only opioid, but different kinds of pharmacological and non-pharmacological approaches. Regional blocks are really easy to do. We all have the ultrasound machine, and the knowledge is also expanding of these blocks. Dexmedetomidine is nice, but not universally superior. It can be useful, especially for the delirious patient, and also both ketamine and dex can reduce the opioid use. Don't forget about the non-drug adjuncts, the safety, family, sleep hygiene, and ICU Liberation Bundle. So thank you very much for your attention.